Dear Health for the World distinguished guest, allow me to introduce you to Dr. Kavita Karunasaagarar, a prominent figure in the field of cardiothoracic imaging at Sheffield Teaching Hospital. Dr. Kavita holds a doctorate degree from UK University of Manchester, where her pioneering research has significantly contributed to advancement of AI, CT, and MRI imaging. Dr. Kavita's career span is over 13 years, during which she has earned acclaim for her groundbreaking work in pulmonary hypertension and pulmonary embolism imaging. Her commitment to improving the quality of life for countless individuals are truly commendable. Currently, Dr. Karunasaagarar serves as British Society of Cardiothoracic Imaging Consultant, where she continues to inspire the next generation of radiologists. Today, we're privileged to have Dr. Kavita here with us, and she will be sharing her insights and expertise on notable cardiac findings on general body imaging. Dr. Kavita Karunasaagarar, welcome.
Thank you. Are you happy for me to continue the talk? Hi everyone, thank you for the invite. It's a pleasure to be able to share some interesting cases with you. I hope I can show you some good cases and some teaching points for you to take home today. As you know, I come from Sheffield. I'm part of the PH team, but it's actually a couple of my colleagues that do the bulk of the work there. That actually happens at the Hallamshire Hospital, which you can see this block, sort of grey and very old school building. So this is the Royal Hallamshire Hospital, and our pulmonary hypertension unit is there. The main cardiac site is actually based a bit further away over the hills in the corner. And we see a lot of general work coming our way. The aim of this presentation is to run through some common and important findings that a radiologist may come across, a general radiologist or a trainee. CT is now very much a bread and butter workhorse for urgent body work and acutely unwell patients. So I am going to concentrate on CT. This talk is really aimed at those less familiar with cardiac disease, maybe general body reporters or trainees. I will hope to show you some examples of cases that demonstrate the potential to pick up some important disease. I must apologize in advance, as it's not possible to cover all of the important cases in one go, but hopefully this will give you a flavor of what to look for, why it's important for the patient, and if you're not used to having the heart as a review area, maybe this talk will help you add it to your mental checklist. Most people are familiar with chest radiographs, so I'm just going to start with this. You don't need to answer this, but a little bit of fun. Have a think about what this X-ray shows. This chest radiograph, there's a little device here. Most people will pick up that that's a surgical screw that's in the shoulder there, but some of you may not be familiar with this. It is fairly common, and it is a loop recorder that has been inserted in the subcutaneous tissues. Most of you probably know what the changes are here if you're used to seeing post-coronary artery bypass patients. So we've got some changes relating to this surgery, and we've got the sternotomy wires, and if you look carefully enough, you might be able to see some of the graft staples. Another case, this time we've got bypass grafting, we've had an ABR put in, and you can also see that hyperdensity, which is relating to the mitral valve calc. Interestingly, in my experience, general radiologists are more familiar with cardiac findings on chest radiographs, but the same diseases are less well recognized or perhaps overlooked in body CT, usually because there's historically a lack of awareness of these kinds of findings on CT. Some of this is due to the limited visualization on old scanners due to various artifacts. Some of this may be due to older trainers being less familiar with heart, cardiac complications and imaging appearances on CT. I'll hope to redress the balance a little, if that is still the case. It's hard to ignore dedicated cardiac work. It's something I do regularly, and sort of almost to get it out of the way, I'm just going to show you some examples of coronary disease. The pathways are well established for this in most centres here in the UK, and this is a lovely example of normal major epicardial vessels. So we have the circumflex here, right coronary artery, and the LAD. This is on a dedicated coronary CT. This is an example of coronary disease, less the spotty calcification and mixed plaque disease here, less so in the right coronary artery, and more dense, heavily diseased LAD over here. These are not dedicated coronary studies, they are staging studies, and whilst dedicated cardiac pathways refer to a well-worked out, often cold patients in the UK meeting CG95 criteria, so stable chest pains, which may be possible angina, these are not the type of patients that usually come in through the acute CT list or general repeat imaging that we often see. This is a nice example of the change in technology. This patient's had several staging studies, and this was performed on an older model scanner. And you can see that there is an aberrant left coronary artery pathway, better seen on the later scanner than on the old one. For this particular patient, they were older. The anomalous left coronary, although maybe of an interarterial cause, which is considered significant, was less relevant. They were asymptomatic. It's important to register it though, because if this has come in as a collapse, maybe a young footballer who had had a sudden event whilst they were playing and came in straight from the field, you'd be worried about an entirely different event, and the workup and implications will be much more significant. So being familiar with these significant findings. In the UK, there has been a move to increase awareness and knowledge of cardiac disease outside of coronary evaluation alone. These are a list of conditions that our juniors need to be familiar with, and I suspect this will be a work in progress as infiltrative disease, by that not malignancy, but deposition disorders such as amyloid, as well as oncology-related changes that impact or may be impacted by cardiac disease become more well known. Other recent publications include this consensus statement from the British Journal of Radiology, BIR, British, and it was a consensus statement with the BSCI and BSTI groups, indicating the importance of picking up cardiac calcifications on routine thoracic imaging. Now, I hope this is not too slow. Apologies, it is going at a steady pace, but it should give you enough time to have a look at these images and think about what the potential findings might be. Referral information here is a 12-day history of increased breathlessness. The D-dimer was elevated, and this is a CTPA done to rule out pulmonary emboli. So if anybody wants, I can go back to this again at the end of the talk, but I'm going to move on to some still images. You should have probably picked up some important findings here. And things that might be going through your head are, was there a PE? Were there infective changes? Is there fluid overload? These are the sort of standard conditions we might be looking for in CTPAs. And the final one, which I often feel might be overlooked, but we're slowly changing the conversation on that, is cardiac disease. Obviously, this is a loaded question. The free answer is there was no PE, so no pulmonary emboli. Most of you probably would have registered the pleural effusions, and I'm not going to pay much attention to the lung changes, but concentrate on the important cardiovascular findings. So you're not going to see any lung images or lung windows here. You can still see the pleural effusions. You can also see that there is a sliver of pericardial effusion coming in. I'm going to talk about pericardial disease in more detail later on. There's also little splotches of coronary calcification. As we get lower down the study, you can see this very dense aortic valve calcification. You get a bit of mitral annulus calcification. And if I go back up, you can see that the left heart chambers are starting to look more prominent than the right heart chambers. Left atrium looks at least borderline dilated, and the LV to RV ratio is markedly different than what you might see if you get your eye into looking at general imaging of what these chambers would look like. So again, on these images, you can see the mitral valve annulus calcification, quite prominent LV. You can start to see it's starting to thin a little bit as we get to the apex. So if you compare the basal myocardial images to the apical images, there is thinning of that myocardium, and there are now several points of disease to pick up in this patient. Now, one thing I would say is, because CT scanners are getting faster and faster, you can get pseudogating, such as we saw with that anomalous left coronary artery. But what I would say is, what I would say is, it always gives me pause for thought if I can see cardiac structures, including coronary arteries, but general cardiac structures better visualized than I'm used to seeing on general imaging. I'm always thinking about disease, and probably the main thing to think about is poor function. If the systolic function is impaired, the more severe the LV systolic dysfunction is, the more likely you are going to be to see the cardiac structures in greater detail. Another thing that might enable better visualization is bradycardia, pauses. These particular images indicate an LAD infarct, difficult to age on a static study, but the thinning indicates this is subacute, fitting in with the referral information, rather than the more edematous myocardium, where we would see thickening. This is a different patient with a very subtle LAD perfusion. So if you look at these short axis images, quite hard to see on the arterial studies, but there is a perfusion gradient here. I'm going to show you better examples of this, but if you window this out and get your eye into it, you will start to see that there is a difference. Again, we've got relative prominence of left heart chambers, and as you come down the barrel of the heart, getting towards the apex, there's less tapering than you would see. Again, the more cases you look at, the more that you reorientate into the short axis and get your eye into how the general structures are, the easier it is to pick up differences. And that lack of tapering in conjunction with the perfusion gradient makes me think about a regional wall motion abnormality in this area. So LAD territory abnormality, septum, anteroseptum, and anterior segments impacted, mid-chamber to apex. Think about the surrogate markers for regional wall motion abnormalities, and if you pick this up on an arterial CT done for a different reason, I would always suggest thinking about an acute coronary syndrome evaluation. ECG is probably going to be your get out of jail free card if that's not been done. Some patients may not present with the classical symptoms. Other patients may have been misinterpreted. Blood work, important, as is the echocardiogram. That would confirm whether there's a regional wall motion abnormality. But remember, in the sick patients, a bedside echo might be challenging. In comparison to the prior study, the myocardial thickness is better retained than here, indicating this is a more recent event. This is the patient's echocardiogram. Everything in that LV is not working very well. If you get part visualization of that RV coming in quite nicely, but enlarged left atrium and very sluggish LV, but the apex is moving less. So So again, think about those changes and how they translate into other modality appearances. And if you have opportunity to look at those other modalities, start cross-correlating that. This is the same patient's MRI images. And the myocardium, this was performed further down the line, the myocardium is starting to recover. So basal segments are starting to contract a lot better. Apex is still sluggish. Remember, we talk about the heart in sort of three sections: base, mid-chamber, and apex. We don't refer to it as proximal or distal. I've seen some non-cardiac trained people do that, so try and avoid that, because when you're talking to cardiology, at the very least, you might confuse them. And it's always good to speak the same language as the rest of your wider team. This is the patient's post-contrast imaging on the MR. So this is late enhancement cardiac MRI imaging. Myocardial post-contrast assessment is challenging, more so than standard post-contrast MRI evaluation, because you have to chase the inversion time of the myocardium, which can be a tricky thing. Scanners and sequencers are improving, but still, you're doing a long-winded study. Patient may not tolerate it, maybe half an hour to an hour, depending on the extent of disease that you're looking for on MR. So this is not our routine first-line study. And as I said, if the patient has presented with a vague symptomatology, generally unwell, the body CT may be the first thing that you actually have access to before cardiology are even aware of the patient. So coming back, I keep coming back to the CT images. Hopefully I'm reinforcing the appearances on CT. And as I said, I'll show you some better examples of the perfusion defects later on. Sticking with this same patient, we mentioned the aortic valve calcifications. Standard CT is actually very good at picking up significant aortic valve calcification. What does this mean? Well, there's a difference between valvular calcification and annulus calcification. You often see mitral annulus calcification, and most people have been trained to ignore it. But aortic valve calcification is really important, hence the reason for the BSCI, BSTI consensus statement. These are reference figures we use in our routine reporting when we do dedicated studies, but the images you have here are the non-gated images. And what it essentially means is severe calcification generally means severe aortic valve stenosis, which in these type of patients means exercise is bad. So if your patients come in as a trauma study, think about, did they run up the stairs and collapse and end up falling down the stairs? Did they lose consciousness after a sudden exertional event? Because what the severity of the aortic stenosis indicates is that they are more likely to obstruct their outflow. There are other conditions that can have outflow and even inflow impact, but aortic valve calcification of this extent is something to really think about putting in your report and raising further assessments, because this will have an impact on your patient's management. One thing to remember though is the sex of the patient. Male and female patients have a different threshold for extent of calcification. So that is important, because you may have less calcific burden in a female patient. So I kept saying I was going to show you different examples of perfusion defects. So this is another LAD territory infarct. This is more of an arterial study. This is a delayed phase study. And you can actually see these phases are both, even the arterial phase is a later phase than I showed you for the earlier cases. And the perfusion defect is much easier to appreciate. The standard portal venous phase is often the one that actually tells you or shows you a good going perfusion defect. And this may not have all of the chest in, but it often has quite a bit of the heart in. I had one of my GI colleagues messaging me about a young man who had gone through the gastroenterology meetings a couple of times looking for vague epigastric pain, altered sort of abdominal symptoms, work up into bowel changes before my senior colleague spotted that something was wrong with the heart when it came through a multidisciplinary meeting. And actually what had happened is they had a massive anterior MI, very old, very established by the time that the staging studies had been done. And they were complaining of epigastric pain. So you must think about the inferior territory being involved. So again, important areas to think about. So even if you're looking at just abdominal studies, look for these perfusion defects, recon the images too, and window them out to help identify the difference between artifact and a perfusion defect. A single phase study can be difficult, but it's important to think about it, and the more confident you are, the easier it will be for you to raise it as a significant finding. Other things that are well seen on CT are fat replacement in old scars. So this is a portal venous phase study, and you see this low attenuation change along an old lateral wall infarct. Probably not an acute relevance unless they're coming in with chest pains when you have to think about the other territories, but may have comorbidity impact for other treatments such as chemotherapy. On MR, we can see this is the diastolic phase and this is the systolic phase. So I'm just giving you stills, and you can see that the myocardium elsewhere is thickening, but this area doesn't. And this is a full thickness infarct with fat replacement, but you already knew that from the CT. Same patient with late enhancement imaging in full thickness, late enhancement through this entire territory. There's lots of information there. So that could have been picked up on the CT. This is a different patient. This patient presented with confusion. They were treated for infection. They ended up having a CT head as a first-line assessment. There's this vague low attenuation region in the cerebellum, within the right cerebellum. They ended up having a MRI, and there's some post-contrast imaging changes indicating this is a real entity. The differential diagnosis was a hemorrhagic infarct versus a mass by the time they had the MRI. And you can argue that there is some hyperattenuation change as well as low attenuation change on the CT. The patient ended up having a staging study, and here we're starting to see other organ involvement. So there's low attenuation changes, peripheral wedge-shaped area in the inferior aspect of the spleen. There's also this sort of redundant or featureless small bowel loop without much enhancement. The consensus was they were having ischemic territories in both the small bowel and the spleen. So what do you think? What are the causes of that? So 3 organ ischemic events, so remember the head, the spleen and the small bowel. So you have to think about embolic phenomena. By all means, think about the proximal vessels. Is there disease? But also think about a central thrombus that could, or thrombus forming entity that could give you a shower of emboli. So here, this is on the same CT. You can see there's a filling defect at the LB apex. And this was thought to be the cause of the infarct, so the patient underwent further workup. Different patient, they presented with these renal infarcts. You can see that on the arterial and portal venous study. They also had low attenuation changes in the liver and spleen. And this turned out to be an aortic valve infective endocarditis with showers of mycotic emboli. These are all non-gated studies, and the reason I show them to you is just as any systemic downstream organ can be impacted by systemic disease, or systemic embolic disease, so can the coronaries. And this patient also had an infarct of their interventricular septum. And these are a series of images that were done on various follow-ups. And you can see there's a perfusion defect starting here. You start to get this sort of saggy appearance. And then eventually down the line, you have an aneurysmal formation and thinning of the myocardium. In these cases, it's important to make sure that there isn't a shunt. This patient didn't have that. They present quite quickly in the context of acute or subacute myocardial injury. But remember, infarcts again can impact any part, including the heart, even if it is a systemic embolic shower. This is an unusual entity, and we've started to see this recently in young, systemically unwell patients. This patient presented with a chest infection. They came in from the community and they had their CT done as part of their sepsis workup. And this is a portal venous study, and what they actually have here is extensive hyperenhancement of sort of calcific attenuation. Most body reporters would be unfamiliar with myocarditic or myocardial injury appearances due to, as I've referenced, the nature of historical training. But the importance of seeing something like this is obviously the heart again is part of the insult the patient has suffered, so it has prognostic implications. This hyperattenuation, hypercalcific process may not be as profound as you see on these images. It can be regional, and if they have presented through respiratory, we've had cases come through gastroenterology and go through to our GI radiology colleagues or from the general intensive care unit, they may not see a dedicated cardiologist, certainly in the UK. It depends on whether a formal referral is sent to them. And you often expect systemically unwell people to have a degree of LV impairment, and it can be overlooked thinking things will improve once the patient improves, and young patients can actually compensate quite well. The other important thing about this is, although it looks very dramatic on CT, it does not look so dramatic on echo or MRI. And it's very hard to differentiate that from classical myocarditis or other causes of LV impairment, particularly if it's global. I've referenced some papers in these slides, and this one is a useful one to be aware of. This is the unenhanced study showing it is calcific attenuation. There is some sort of literature, mainly as case studies, indicating that although this is a rare condition, it is well recognized, but there is very little longitudinal information. And the concern is this is happening to young patients. It's happening to, it's impacting quite a large amount of their myocardium. So if you have that much additional material there, there must be some sort of restrictive type impact to the myocardial function. And although there is some indication that there might be resorption over time, it is not clear as to what actually happens to these patients. So this is something to monitor and be aware of. But I guess the important thing is, if you're doing body imaging and you see this, think about the phase of the study, think about why you're seeing this. It may or may not be related to renal function. A lot of people think, oh, it's because there's renal failure, but you can see it's very unusual for it to impact the myocardium and not the other soft tissues. So definitely think about flagging this up and getting a dedicated opinion. Moving on to different types of disease, these are examples of how unenhanced and arterial phase studies can demonstrate different information. This is a patient that has a subtle low attenuation filling defect, or, well, it can't be considered as a filling defect because we haven't given contrast on this unenhanced study, but there's definitely an entity here. When we give contrast, you can see the filling defect. with this low attenuation lump indenting the protruding in from the back of the left atrium. These patients actually had a stenotomy, and this was a recurrent liposarcoma. Unenhanced studies may also be helpful in identifying calcification better than contrast. So always look at your historical imaging, particularly when you're dealing with non-contrast, when you're dealing with non-gated stuff, because the older imaging may actually move your interpretation into a more confident and accurate group that a standalone study alone you may struggle with identifying the differentials or making a conclusive decision. So I've gone through all of the cardiac findings, but what about the pericardium? Well, this is an important structure, often overlooked because it can be insidious, but there are acute presentations. Most people will know about constricted pericarditis from the TB pattern. I'm going to show you examples of that type of disease later, but to start off with, as images, we also always need to know what's normal. And actually the normal pericardium is quite often hard to see. It's a barely visible sliver here. This is an arterial phase study, and there might be a hint of fluid. Often, as you come along the inferior aspect, you might see a little bit of more confluent fluid, sometimes in the superior recesses. Don't mistake that for lymph nodes. Be aware of your pericardial recess distribution. This is an example of diseased pericardium, and this is more of a subacute inflammatory case. And you can see this is a venous study, and there is a thickening in the pericardium here. When I scrolled through the actual study, it was easier to see that actually there is only a sliver of fluid in here, and this is thickening of the parietal and visceral pericardium. But you need to get your eye into fluid attenuation and the differences in the types of contrast phases or absence of contrast that might impact the appearance of the pericardium. So on a venous study, the hyperattenuation myocardium and the pericardium have different differentials to think about than if you saw this attenuation on an early phase or an unenhanced study. It can be difficult on just a chest CT because you probably only got the CSF to compare with, and if you've got an unwell patient, you might have a lot of streak artifact. If you have pleural effusions, that might help, particularly if they're simple effusions. This patient does have pleural effusions, and you can see its low attenuation change. They came in with a delayed presentation of breathlessness. The CTPA was done as part of their acute decompensation admission. So young patient, unwell for several months, originally started with flu-like symptoms, but developed persisting breathlessness. They actually ended up having an abdominal ultrasound because there was a concern that they were becoming bloated and that they were developing ascites, but there's no alcohol history, no indication of or markers of chronic liver disease in this patient. This was all a very short period of presentation, although from a cardiac and pericardiac point of view, it was already established disease at this point. So the patient got boggier and boggier. We've got edematous subcutaneous tissues. The study was done as a CTPA to look for PE, and that makes it difficult to say much more than the fact that there is a pericardial effusion. But with the eye of faith, you might start to wonder whether there's a little bit of enhancement here. Again, different phase studies, this is much harder to pick up on the early arterial, in this case pulmonary arterial phase study, versus the venous study. And here you can see there's low attenuation change, and then there's enhancement in the sliver of parietal pericardium, and possibly also in the visceral pericardium. So this was a non-gated study. This is the patient's MRI, and you can see that the simple fluid that's within these two layers is there, and you have this thickened almost susceptibility artifact on their late enhancement imaging. It's quite difficult to pick up enhancement depending on the type of sequences you run and the distribution of it. And actually the CT was very helpful here as part of their general cross-modality evaluation. So this patient actually went on to have surgery to try and open that up, because they really were quite poorly by the time they presented to us. Other markers of this include changes elsewhere with the atria and the ventricles, and I'm going to show you some examples of that with the next case. So this is a patient that was referred to us with progressive edema, ascites, and right pleural effusion. Referral information was also stated the study was being done to exclude the presence of malignancy. I've given you the scout image because you can see there's a bit of fluid about. There's probably bilateral pleural effusions. You've got a hint of a floating bowel here, and then you've got this really funny calcified appearance along the inferior aspect of the heart, along the diaphragm. And this is an odd-looking lumpy thing with peripheral calcification. You've got dilatation of the atria, you've got indentation of the RV, which is more amenable to pressure changes than the LV. And you're starting to see that maybe the ventricles are starting to be a bit conical, and there is that band of abnormality extending along the inferior aspect that you saw on the scout images. As you go further down into the abdomen, you actually see ascites. A lot of people just looking at this their first thought might be chronic liver disease, usually due to alcohol excess or other chronic liver disease conditions. And you see all the hallmarks of established cirrhosis, nodular liver, bulkiness of spleen, varices coming in there, and I haven't really paid much attention to showing you more images of that, but this was the patient's MR. You can see all the bucket loads of fluid. This was on the planning images. The spleen is quite big, and there is that lumpy bumpy peripheral calcified mass with indentation of the ventricles. So they're continuing to fill up with fluid, basically because the heart can't work so well. The atria are big, inflow and outflow is impacted. MR can give you an idea about other differentials, but we don't use it to definitively talk about constrictive pericarditis. That would still be a right and left heart catheter assessment, certainly in the UK, and we'd be looking for equalization of pressures. We can get some changes on real-time images. That's why these are such low-resolution pixelated images. And you're looking for straightening of the interventricular septum. But as I said, these are all supportive findings. If you don't see it, you would, and there is still a concern about constrictive pericarditis, you would still need to think about right and left heart catheterization. A different case, but a similar type of disease. Again, this was caseous TB with a big lump of mixed density sat around the heart. And that's the volume rendered image that you've got spinning in the corner. Soft tissue disease is also important, and these are a series of non-gated images done on a patient with known non-small cell lung cancer. They had treatment for this, and this was on their follow-up imaging, and they actually developed recurrence in their pericardium. So reasonably normal looking pericardium here, a bit of coronary calc, probably a very uninteresting heart just off that static image. You're starting to see fluid in the pericardium. As we go on to the later phase images, there's a bit of increased activity on the PET scan there, and you're starting to see a nodular appearance where the infiltrative disease is really starting to take soft tissue hold. One caveat I would say as well is we do see some very aggressive inflammatory disease, so it may not be cut and dried. Look for other markers of disease elsewhere that help guide the type of disease that you're dealing with. As body images, systemic evaluation is always important, and always look around the rest of your available images and the historical imaging. Entirely different case. This presented in what we call a NELA pathway. So this is a National Emergency Laparotomy Audit that runs here in the UK. I presume there are different versions of this where the surgeons are interested in picking up an acute abdomen quickly so they can decide whether laparotomy is needed or not. Cross-sectional imaging unfortunately throws spanners in the work, and the reason that you've scanned the patient may not be what's actually wrong with the patient. And there may be other even more critical findings to see. So I'll leave that image up, keep that in your mind, and I suspect this might be a case we want to come back to with the questions. But this patient didn't have a hollow viscous perforation. They're a big patient, so you can see all of that artifact due to their body habitus. But if you look at the top of the images, something is not right with the heart and the pericardium. And this is a hemopericardium with an acute type A dissection, and that's the top of the images there. So hyperattenuating pericardial fluid. The LV is also not normal. This was actually quite a young patient, and you can see the intimal tear with the altered attenuation in the true and false lumen. Of all of the pericardial disease to pick up, don't miss the hemopericardium. It is really important, and I think if you are a reporter in the non-vascular or non-cardiac specialty setting, it can be easy to walk past this, particularly if you're not used to seeing this that often. And time is of the essence, so always think about it, always phone a friend if you spot something like this, and get that opinion quickly. Different patient, again, this is an unenhanced study. Look at the attenuation of that pericardial fluid. It is hyperattenuating, but quite hard to comment because you've got streak artifact. This was a sick patient. They have a dilated aorta, there's intramural hematoma, and this is the coronal view. And you can actually, if you look at that gallbladder down at the bottom of the images, you can see that the attenuation between the pericardium and that gallbladder fluid is quite different, but it's similar to the vascular and cardiac attenuation. So we should be thinking about blood. And hemopericardium does look different, but the phase of study can throw you. So think about it. If it's large enough to put a region of interest on there, do so. If you're not sure, again, get another opinion, because it is important not to miss this. This is an example of a patient from our PH group who's got a simple pericardial effusion. So it's a larger effusion than what we see here, but this is the critical finding. These were long-standing changes. Okay, so I'm getting to my last round of last couple of sets of topics, leading on from the PH work. Because we are a PH centre, again, this was thanks to one of my colleagues who's one of the core PH reporters. These are examples of non-gated images. I often have juniors and external images coming in where people have done a CTPA because they've got a breathless patient, and the report says no PE or no acute PE, and they may even say no right heart strain. Looking at these images, the first thing that crosses my mind is the reporter is somebody unfamiliar with cardiac disease, because this is abnormal RV appearances, and as highlighted there, we've got thickened RV myocardium, dilated RV, there's interventricular septal bowing, so this is significant pulmonary hypertension. You may think that is rare, but it isn't. Pulmonary hypertension has multiple causes. And what our national PH team, we're apparently one of the largest, if not the largest group in Europe, and one of the largest imaging cohort group, and we see a lot of different types of disease here. And what often happens in the multidisciplinary team is sort of sift through all of the causes of pulmonary hypertension, and PE, chronic PE, and treatable pulmonary hypertension causes from a pure pulmonary hypertensive disease process is a subgroup. The front runner still remains left heart disease, and that is something to think about. And this is the largest group that present in the acute medical setting. Moving on to heart, the vasculature that plumb into the heart. These are important vessels, important great vessels to think about. This was a patient that was mobile, was walking, came in with mild, unexplained chest symptoms, but they had chest pain, and the ED department was very keen to exclude PE. Those of you familiar with the great vessel anatomy, and you've seen some of that on the earlier ischemic case I showed you, will know this is very abnormal anatomy, and this is actually a congenitally corrected, as in the patient has done this herself, probably before in fetus, in utero, so they've corrected their great vessel transpositions themselves, so they haven't had any intervention. What is the importance of this? Well, the adult congenital heart disease groups can present, quite surprisingly, but given the fact that we do so much body imaging these days, they're not entirely uncommon. The rarity or the percentage of cases is still probably small, but we do see them increasingly because we do so much body imaging, and some of it is more significant than other, but it does have impact on how you get a good quality study. If the pulmonary artery is not where you expect it to be, if the patient has had surgery, that impacts where the connections might be, or as in this case, the plumbing is such that your contrast goes to the wrong place. So this is a sinus venosus defect with partial anomalous pulmonary venous drainage. Partial anomalous pulmonary venous drainage is actually something we see every now and then. They pop up. I probably see a couple of it, or certainly comes through my hands every year. And there's various subgroups of it. So the sinus venosus defect is more rare, where everything is sort of closely connecting together, but you can get isolated connections coming into the SVC without the ASD down within the atria, the atrial septal defect, or you can see on the left-hand side where the left upper lobe drains up into the innominate vein. I am going to finish with that. It is very much of a snapshot view of body imaging that I've shown you. There are many other significant findings and different disease presentations, but if you start watching out for these in your general work, you'll learn on the job, and there's more training information out there that you can reference. And as I said, think about your other colleagues who may be more experienced in this, learn from them, and learn from your own patients. Thank you very much. Any questions?
Thank you, Doctor. Actually, it was very informative lecture. Thank you so much. I'll be waiting for questions, and it was really interesting to know that females have less burden than men in this showing presenting to aortic calcification. And then you emphasize a lot on hemoperitoneuum. So I'm going to be waiting for questions from audience. There were too many good details on this cardiac imaging that
Does anyone want to see any of the cases again? I think we've got a few minutes. Or I may have
It was amazing.
I may have fried everybody's brain cells.
Yes, actually, we're just thinking. We're
I
actually,
might, whilst we're waiting for that, I just wanted, because this is the one that I really don't want people to walk away from, is that hemopericardium, because I think it can be a challenge, particularly in the really sick patients, and if you've done it for a different reason. If it's come in as a acute dissection workup, you're home and dry, it goes to the right team. It's when it comes in a odd way, and I think our index, our threshold for imaging, I think in the US and Canada and some of our Scandinavian countries, we have emergency radiologists now who are probably more trained in kind of this kind of pickup. So they'll be doing a range of body work. But in the UK, we haven't quite gotten to that, probably staffing issues and the amount of work we have. So for us, any specialty group can pick up acute work and on-call work. So that's why this kind of reinforcement is important for us. And the same for me when it's to do with uh, abdominal work, or I don't do as much neuro or spine work, but think about the differences for discitis, all of these things. So regardless of which subspecialty is your area of interest, we still need to remember as body images of the other differentials to think about, and always go back to what the patient presented with, not necessarily what the referrer has asked you for. The patient is the one with the problem. And the referrer's question is really important. You have to answer it, but presentation with chest pain or epigastric pain or breathlessness, think about all of the other differentials.
definitely, definitely, especially when that in an emergency acute setting when everything gets very corrupted and like everybody's trying to work something out of this patient. We're trying to treat the patient, not the.
Yeah, and I think the other place to think about it is in the trauma setting as well. If they've had a penetrating injury, if they've had blunt force trauma, and you people look for the broken bones and the blood in the brain,
Yes,
but they may not
like
think about, they may not think about cardiac contusion and cardiac injury or great vessel injury in that setting. So again, for us, our vascular radiologists are involved if it's noted to be a hemodynamically unstable attendance. But often, and I don't know whether this is because some patients compensate better than others, they may come through as a stable bastion, so a stable trauma assessment, and you may get an unexpected surprise there, because the heart is actually able to, even with a puncture, not necessarily sort of gunshot injuries as you may see in the Americas, but here we can get stabbings and other sort of more discrete injuries, and the myocardium closes itself off. It's the same as when you put a pacing wire. Those of us who are long in the tooth and have done pacing, it's not that uncommon to pace the diaphragm. You go through it, and it keeps its configuration. It keeps itself contained, and you don't end up with a pericardial effusion. You still have a functioning patient, even though you pass through the RV.
sure. We have one question, doctor. How you differential hemopericardium from TB pericardial effusion? I think it's based on imaging. The question is like,
So, sorry, could you just repeat that for me?
how do you differentiate hemopericardium from TB pericardial effusion?
Okay, I think hemopericardium, so you're looking for hyperattenuation in the acute setting. A TB patient, and I presume the query is relating to sort of the softer caseous calcification, shouldn't present acutely. So this is and this is before you get sort of the formed calcification or sort of an exudative material. An exudative material can be hyperattenuating, but the presentation scenario should be different. So remember, the imaging is part of the assessment. If you see this, you need to make sure, and you don't have the patient history, you must make sure that this isn't an acutely unwell patient. if they are happy and having a cup of tea, sat up in bed, or have come into clinic breathless and infected from other points of view, then you can start working up the infective inflammatory side of things, but you can do it with a little bit more room and less worry. Most of the infective pericarditis that we see in the UK are actually the inflammatory type. So you see that enhancement pattern, but you have to think about doing a post-contrast study where the soft tissue contrast uptake phase is there. So if you do it too early, you may not see that hyper-enhancement. You may not appreciate the difference between the pericardial thickening and the fluid within the pericardium. So people often can call this all effusion, but actually there is thickening and there's fluid, and then there's the different layers of thickening, which is where, if you do a venous study, and we often so post-COVID, we've seen a run of delayed, really diffuse inflammatory change. I think our immunology group and infectious diseases group are looking into this because we don't really know why, but it seems more profound. And you see this huge area all the way up to the arch vessels sometimes, following, because the pericardial sac can go all the way up beyond the aortic root. And it's all this inflamed, thickened pericardium. So when we're working these patients up for pericardectomy, you need to know the extent of damage and what is impacted. So we tend to do a venous assessment for those, just as we would do with when we're looking at pleural disease. The multi-phase imaging, though, does give you incremental information. So always look at all of the imaging that's already being done, even if you're not performing multi-phase imaging on that sitting. Any more questions?
They're showing so much like they're grateful for your great presentation, and I just see thank yous.
That's okay. At least I haven't put people to sleep.
Well, we're gonna have a record of this presentation, like usually in a week or two, so people who kind of missed it during for internet corruptions, they can get access to it later. Amazing.
Lovely. If you do get any questions down the line, please feel free to pass them on to me. I think
see any so I think we're good for today. Thank you so much, Doctor. Thank you so much. Actually, that was very informative for me. Kind of brought a new horizon to my view. I think we're good for now. Have a wonderful afternoon and evening, Doctor. Hope to see you with next lectures.
Thank you for inviting me. It's been a pleasure. Thank you very much.
Thank you very much. Have a wonderful day.
Bye-bye.